This is BJ Miller, palliative care doctor, and my dear friend and colleague, Karen Schanche. Say hi, Karen.
Hi, everybody, and hi, BJ and Sonia. I'm Karen Schanche. I'm a palliative care social worker as well as a private practice psychotherapist that has a specialty in sex therapy, couples work, individual work, in this whole
Mhm.
area of sexuality and intimacy.
Beautiful. Can't ask for a better person to be on this call with us, Karen. Thank you.
Honored.
So we're here. We're just going to answer a few questions that were left over from our webinar today on sex and intimacy.
Hey,
So over to you, Sonia.
Thank you, BJ. And thanks for being here, Karen.
sure.
Okay,
Thanks.
one of the questions that we got at the end was, my husband passed away 5 years ago, and I have been alone since. The thought of dating still feels like cheating. Any suggestions for how to go forward? I have been in grief groups, counseling, but I'm still not able to bridge this void and move on into the future.
Well, I think you're in a brave new world in a lot of ways. First, coming into the world um, on your own without a partner right now, but with your partner in some ways through the grief. And just how are you embodying yourself right now, essentially, would be one of the questions I would ask. And I'm biased when I say this, so you need to know it probably would be helpful. I don't know of any group that's going to address this. You need to have a sense of safety first, and maybe an individual therapist who can deal with sexuality, intimacy, body image, and grief would be a good way to go. Because I think just stepping out in the world right now, you're also going to be facing, as we come out of COVID, everybody's in trauma and everybody's skeptical of each other. And what I don't want you to do is interpret that as there's something wrong with you, which is what happens and is what's beginning to happen. People get more fearful. It heightens fear. So going slow, really going step by step on this rather than rushing into dating or rushing into internet dating or online or something like that. I think people used to do that before COVID, and you might get a lot of advice to do it, but you need to feel emotionally safe. And if I think that's always a good place to start and to ground, if you know that word, to really take a deep breath or a pause to really check in with yourself about, does this feel safe enough right now to take the next step? Is that helpful?
That sounds beautiful to me, Karen. I would just add, this may be that you need a little more time with your grief. If you're not feeling the call to intimacy yourself, maybe you're feeling like you should be, or like maybe like Karen was suggesting, like avoid this idea that there's something wrong with you if you don't want to go there yet. And on the other side, avoid the sense that there's something wrong with you if you do want to go there yet and just don't know how. All of the above, it's all welcome here. But this point about maybe not feeling quite ready and maybe feeling like it sort of feels, if I heard you right, somehow dishonor to the partner you've lost to head in there like you're cheating. That just may mean that you're not far enough along in the grieving process to really reach outside yourself just yet. So I like what Karen was saying. I just pay a real close attention to your body, what's going on inside of you.
Can I also add to that? Just beautifully said. And I think it's like weaving a tapestry. You're reconstructing the meaning of loss in that your husband is in your heart. You're not being disloyal, but kind of updating your loyalty to come back into body yourself and learn how to have both your own sensibilities, your own body. And that's going to bring up maybe some more grief, but love, the opposite of love is grief. It's not hate. So the idea of letting yourself go through that in a safe way and understanding the meaning of that for you and the pace of that and keeping it safe for you emotionally while you're doing this. It is like you are dealing with your grief, and I think you're beginning to take the next step into a transition that's a little different. So it may feel like you're not dealing with grief all of a sudden, but you actually are. It's a tender
Yeah,
place. Yeah, very tender. Yeah.
yeah. And grief can include longing, can include desire, etc. That's not anti-grief at all. It's
That's
all welcome in that bundle.
Right, thanks, guys. Beautifully said. The next one is, my husband has a colostomy bag and it's making any kind of intimacy very difficult for me. I know he can see my reaction, but I can't help how I react to it. Do you have any suggestions for ways we can be close that don't involve physical touch?
Oh, wow. So that's very interesting. Have you, first of all, I wonder if you've been able to talk with your husband about it and identify it not as a character flaw or anything of either of you, but it's a hard one that is a physical place where you're running up against some kind of emotional process, probably. Um, Not involving physical touch is a little hard, and it's interesting how the connection you're making is to a colostomy bag and physical touch, you know? So are you touching anywhere else? Are you aware of the sensuality of each of you rather than the mechanics of medical care and physicality of the caregiving responsibilities maybe you and your husband are both trying to do, which is different. It's a different kind of touch. It's for a different reason. And BJ, jump in if you want to add to it. But
Well, I think you're, oh, sorry, Karen.
oh, go ahead.
Yeah, I was just going to build on what you were just saying there, that this could have something to do in part too with the role reversal, the role switches. Now that you're more in this caregiver role, that doesn't necessarily feel very sexy, and that treats the body as something different. So part of what may be happening here is you may need to refashion your notion of your role in this mix. That's one point. Communication's huge here. There's no shame. A feeling of repulsion, repugnance. It's not like we asked to feel these ways. They just come. That's the nature of feeling. So there's no shame in it, but it'd be something to talk through, talk about, acknowledge, work around, maybe even work with at some point. But first, I'd start by de-shaming it. It's not your fault for being somewhat pushed away by something like a colostomy bag.
And it's not your husband's fault either. You know, it's sort of
Exactly.
the body does its wonderful stuff the way it needs to stay in life. And colostomy bags are part of that. So to be able to language it in a physicality, we're so body negative in our cultures. And when something happens physically to change our appearance, that can create a backlog of a lot of emotions that I think can get kind of mixed up with the caregiving role change, with everything else. And it actually truncates intimacy a lot of times. And in medicine, we're not really good at helping you pull those apart again and talk about it in a, you know, the colostomy bag may not be sensual, but there's care that we can do around that and expect, you know, you're looking at different adhesives, looking at different timing as well, and changing the bag before you guys make love or have physical touch. Also playing with different parts of the body to touch in a different way than caregiving, than the cleaning, than the functionality of the help and loving care you're giving each other, but relanguaging it so that other parts of the body can be brought in a way that heightens sensuality and intimacy, and is part of the playing field. So it's out of the performance kind of capacity that we often have and call the only way we could be sexual. So some other thoughts about that.
Thank you for making that point about performance. It's such a intimacy killer, and sex is so wrapped up in it. That's something definitely to untangle. Yeah, it's so beautiful, Karen. I love doing this with you. I was just going to say too, like intimacy. How would we define intimacy? Touch certainly can be intimate. Touch can be anti-intimate too. I mean, but I would say that intimacy, for my money, I wonder what you'd say, Karen, has something to do with deep honesty. And so that vulnerability, that deep honesty, that realness can include your own distaste for the ostomy bag. In a way, that is, you're being honest about your feelings about that is itself potentially intimate. So nothing to be ashamed of, nothing to wish away, something to work through and around, like we're talking. I just wanted to make that point, that in some ways you already are intimate just by even noting that response in you.
Yeah, and I think the idea of taking the appliance or the body change out of the equation and dealing with that separately, but coming back into what's it like to see each other again, to be alive, to be dealing with, oh, this is not sexual. I mean, that's at a different level than a life-threatening issue. And you've been through a lot of those traumas potentially with any medical procedures that involve these kind of surgeries to even beyond that. But you know, the idea of coming back to a presence with each other that's not so medically urgent, but okay, this is the body a little bit different, and maybe getting curious about it when you're ready, and getting curious about your approach that physical touch has gotten linked with this, maybe not so useful now. It maybe was at one point, but you can broaden the playing field again. And that may need some coaching to do, but it's a good thing. And I think it takes it out of the performance. I don't know how you and your husband were before, but most people have that role really ensconced.
Yeah, and treat it like you're starting this is a new body, and in this way there's new routes to intimacy. So be very careful, like with the performance thing, but also be careful about comparing now to some other time that's gone now. So, you know, sure, there's room to grieve that, what's gone here, but the way forward may be something very different from what you guys are used to, and it'll take some experimenting to find that out, to figure that out.
Yeah, and it also doesn't mean you've lost your sexual verve. It's just finding it in this change. The body's going to change a bit, and if it's had surgery, your husband may have some scar tissue that might not be as stimulated, but other parts may, as a compensation over time. And you also may find that to be true. And again, talking about, you know, this is hard for me, as long as you know that it's not about you, it's about this ostomy and me coping with that. Let's keep talking about that separately, but making that differentiation, because you're attached to your husband and you love him. The colostomy bag is just another piece of equipment that sustains at this point and has to. But one could extrapolate that. It's a great question, because somebody who's had a mastectomy, or somebody who's had a loss of limb, or, you know, anything that's changed the body from what that sort of idealized weird thing that we've done in our culture does to bodies, instead of idealizing what the body really does to take care of itself and deal and be in life and resilience any way it can. You know, so I don't know. This was some of my thoughts.
Yeah, that's so good. And I'm getting a lot. One more thing I want to say anyway, Karen, you can keep going as you like, but maybe to the original question about other ways besides physical touch, like we've been talking, I would not give up on physical touch. There just may be new ways into it, but you don't have to ram anything here. So it may be safe enough to start by holding hands and watching sexually explicit film, or, you know, who knows what. It doesn't have to go right to lots of touch, but holding hands can be a start. And even vicariously watching something sexual might be a way in. I don't know, that you just have to, it's a lot of trial and error.
So riffing again on this, I want to speak to, there's a larger population than one might think of people who don't touch, who haven't touched throughout their relationship or part of their relationship. They did, and then it's 40 years later and they don't. And so the idea of looking at, you know, the five senses, touch is one of those, but could you share a moment, if you share music or art or any kind of a stimulus to one of the other senses that is not about medicalizing, not about anything functional, but just about enjoying a pleasuring moment, learning about the idea of pleasure and sensuality again. And where in your body can you track that? You don't have to touch, but you can be in connection with each other, because you're partners. There's an automatic attachment going on. You co-regulate each other from a physical level to an emotional level. So taking a step back and finding out in a curiosity versus a judgment, especially if you've never touched before, or don't emphasize that in your relationship, or there's a religious belief that keeps you from doing that. The five senses are great. And if you only have one or two senses working, use those if it's not one of those is touch, because the other are heightened to the ones that aren't. Hard of hearing, you might see your visual is much more acute, or your taste. So enjoying a good meal together can be an incredibly erotic experience. We're talking about putting eros back into one's life, and that defines itself not just in a sexual style, but in terms of a position or something, but it's really about the joie de vivre, the joy of life, that deeper level of connection and intimacy that you don't usually give away to many people, except perhaps your partner, or you can re-find a way in after going through illness and all kinds of other stuff to reconnect with. And that's your own private world of safety and connection, no judgment, and it's far better than just what we usually think about as sex. You know, it's sort of like you're in a playing field that's massive in terms of this spectrum, and it's lovely to explore it as long as you two are in a mutual safe place to do that. Safe emotionally, yeah.
And those new signals may very well be subtle. So just it's part of this is a reattunement, a recalibration. It may not be these explosive sort of porno orgasm-y things that get confused with intimacy. It could be a really vague, subtle signal. So part of this is paying attention on a different level to each other and yourselves.
Absolutely.
So yeah, well, there was a lot of answers to your question.
A lot of great answers, though. That's actually the only additional questions we had, but I was thinking it might be helpful for one of you or both of you to speak on ways for people to bring this up with a clinician, or things to ask before a surgery or before a treatment to understand what you might be able to do or not do afterwards.
Do you have thoughts, PJ? You can go first. You're smiling.
I'm smiling because I know you and I have talked about this, and we're both of us very much aware of how this doesn't come up in a typical clinical encounter, and what a shame that is. So I'll get started by simply saying, there was one thing, as Karen was pointing out, safety is really important to intimacy. So, and physical safety, emotional safety, psychological safety. So especially on the physical front, depending what's going on with your body, it may be important to ask your physician if, to what degree is it safe? Where are there physiologic boundaries? Where might you accidentally hurt yourself with some idea of sex? So that may be a reason to talk to your doctor about it. How to talk to your doctor about it is inherently clunky, mostly because the way they'll probably be a little shifty on it. But this is where you got to be a little daring and say, hey, doc, I really want to talk to you about something that's very intimate. Sometimes you might want to preface the conversation to set it up for the doctor. Sometimes that means because there's students in the room or other people in the clinical encounter, you might say, hey, doc, if you like, it could be a very great teaching moment for students too. But if it helps, you might say, hey, doc, can I talk to you about something, just the two of us, or just the three of us if your partner's there? And then simply wait and say, I'm worried about, if it's a treatment coming up, I'm worried what this might do to my sex drive or my sex life or my arousability, or whether sex is safe anymore. So this new treatment you're talking about, doc, is that going to affect my sexual life? And if so, how? And do you have ideas or anyone I can talk to or think through, how to work with this? That kind of thing. But it will largely fall to you to push the conversation with your doctor or your nurse, your clinical team. Both Karen and I really wish that weren't the case. We wish it were much more normal for any doctor or clinician to bring these issues up, because we see this sexuality and intimacy as essential and primal, part of fundamental human experience. So we got a lot of ways to go on the medical training and clinical encounter world before you can expect those guys to bring it up, but we'd certainly push you to bring it up on your own behalf.
Absolutely. Again, I think that's such a well said, and I think sometimes for people that work with like a cancer center, you're having people in infusion. A lot of nurses, sometimes they can advocate because a lot of times they feel comfortable about bringing it up, or the social worker might, or other clinicians there. But I know in the cancer center where I'm working, maybe because I'm working there, I don't know. It's always an insistent thing. We've done in-services on making an assessment as normalized with sexual health as it would be with blood pressure, temperature, everything that people take when they sit in the office before the doc sees them. And what about your sexual health? Are there problems there? And languaging a few questions. It's been hard because the medical assistants feel uncomfortable about it. So we're having to have people normalize that. And then when we do, it's like, okay, we can do that. And people really, they're kind of confounded. They stop being nervous a lot of times because they aren't expecting that question. And it's a doorway into maybe being seen in a little deeper conversation too. The hope is there. And I think with our palliative care, we include that. I did with BJ when we worked together at UCSF, and then also now where I work. It's part of our screening process for symptoms that matter. And once they're part of the physical spectrum we talk about, because many people, it does matter and nobody's mentioning it. And some people don't want to mention it, and that's okay too. No judgment around it, but we treat it as though it's like everything else that's important to the degree somebody wants to make it that way. And if they don't have somebody in their area, we try to find clinicians. It's really hard still to find trained, good sex therapists that are reliable, that aren't that are people you want to send people to for treatment still. But we're getting better in the mental health world about training people as well. So it's still going to be a long time though. So I mean, if you have a good rapport with your physician and want to just shake things up for playing with them, you can ask them and watch them squirm, and you can say, you know, this is like what's really important, and I don't know if you feel safe enough with that person, and many people do over time. You won't derail them. They'll probably appreciate the break to become alongside you in the humanness of this versus them being always an authority, because nobody's an authority on this. And I know sometimes when I've asked on patients' behalf, what's important to them, an example, a cancer patient who's on immunotherapy, and they loved oral sex together, she and her partner. And what nobody seems to know is that if she has oral sex while she's getting the immunotherapy, is he going to get a dose of it as well? And asking that question it kind of went to the big pharma companies, and so far we haven't gotten an answer back, but nobody had any data on it. And they said, you know, that's a really good point. So going back to the earlier times of chemotherapy, where it's still pretty toxic and secreted in different ways for people, we were kind of just using those axioms. But a lot of the gene therapies and immunotherapies now change every 6 months. So nobody's really looking at the side effects of that yet. I think some of the bigger cancer centers are in Canada particularly are starting to look at that as a quality of life issue that goes along with everything else. And it's important, if that's how you've connected and you enjoy those kinds of sexual practices, then why not, you know? But nobody seems to know. So to be able to talk about that and decide what can be safe for you and your partner to still work with sexuality issues or practice different sexuality kind of processes that give you resilience and care and comfort and connection. And that'll really confound your physician, but it actually may be a really good discussion to drop you into pretty nice levels with them. So
yeah.
Awesome. Well, thank you both very much. That was really great conversation. Appreciate it.
It was fun.
Thanks for being here, Karen.
I'm honored.
Thank you, Karen.
And your audience is lovely. Thank you.
It's so lovely working with you again in real time, Karen. Thank you, thank you, thank you. More to come.
Bye, guys.
Bye-bye.
Bye.